Thank you for joining us for our Medical Needs in School workshop on cystic fibrosis. We're joined today by Dr. Imogen Rose. Dr. Rose has been a paediatric consultant at Ipswich Hospital since May 2019. Her areas of special interest are cystic fibrosis, paediatric respiratory medicine and allergies. And today she'll be giving us a presentation on cystic fibrosis. The workshop will be recorded, and both the recording and Dr. Rose's slides will be shared on the Radboud Trust website, which is www.radboudtrust.com/MNIS. Over to you.
So good afternoon, everybody. So I've been asked to talk about cystic fibrosis and how this is then relevant for schools. So I thought just this is a brief outline of my presentation today. So I thought it'd be useful to go through what cystic fibrosis is, how it's diagnosed in children, what causes it, how it affects the body, how we treat it, the CF team here at Ipswich and at Addenbrooke's, what schools can do to help both children and families and us, and resources available to you. So firstly, what is cystic fibrosis? So it's an inherited genetic condition and it affects about 11,000 people in the UK. 2 people die a week from cystic fibrosis and 5 babies are born a week that have it. 1 in 25 people carry the faulty gene, and most of these people will be unaware of it until they meet somebody else who may also carry the faulty gene. It is sadly a life-limiting condition, and it means that 50% of those with CF will live now until they're about 47, 49. The data from 2019, which is our most up-to-date data, says that. And actually it's improving all the time, which is really good news. So 12 years ago, it was about 40. So we are making improvements in that. So what is cystic fibrosis? So as I said, it's a genetic condition, and that faulty gene that is affected is important for the body's ability to make or direct a protein called cystic fibrosis transmembrane regulator. And essentially it's a channel in every cell's surface. It's that green channel in the picture in the healthy cell. And it's important for moving chloride out from inside the cells to the outside of the cells. And why this is important is that water follows chloride. So when that channel is not working or it's blocked because of this protein being affected, it means that water travels into the cells following the chloride. And it means that the mucus that is normally there in the lungs, which is normally thin and moving bacteria along and out of the way, actually becomes really thick and sticky and traps the little hairs on the cell's surface and therefore traps bacteria and causes problems. So you get this mucus that is thicker and stickier, and this can affect every cell within the body. So how is it diagnosed? Well, most of the time it's diagnosed on newborn screening. So the little picture in the top right is of a heel prick test, and we've been doing this since 2007. So between day 5 and day 7, all babies in the UK will have this little blood test from their heel, and we collect the spots of blood and we test for rare but important conditions, of which cystic fibrosis is one of them. It also can be diagnosed as a result of carrier testing. So when a child is diagnosed with cystic fibrosis, parents will also have genetic testing as well, and this is important for future pregnancies and sort of advice about that. When we have families that have children with cystic fibrosis and then they have subsequent pregnancies, they are always offered antenatal testing as well, and that can either be CVS, which is chorionic villus sampling, so that's just sampling from the cord, or amniocentesis, which is sampling from the fluid surrounding the baby. If we have a child or adult that presents with symptoms that could be cystic fibrosis, they actually have something called a sweat test, and that's this picture down in the bottom left there, where we attach a little machine to the forearm and we actually collect the amount of sweat that people are producing. And we're measuring the sweat chloride in this. And if it's greater than 60, that means that child has cystic fibrosis. So what causes it? Well, we know it's a genetic condition. We know it's inherited. It can't be caught or developed. So if you're not born with CF, you won't have it, but you could be a genetic carrier. And as I said before, 1 in 25 people will carry the faulty gene. Everybody that actually has cystic fibrosis will have 2 faulty, or what's known as mutated, genes that will cause the problems. There's at least over 2,000 mutations that can cause the problem, and we're finding new ones all the time. And the picture in the top right there is really that although we have over 2,000 mutations, these are split into 5 different classes, and it depends on the mutation that determines how much of that CFTR protein is working and how much of the chloride channel is then affected. You can have CF children with milder disease and those that have more severe disease depending on their genetic mutation. The mutation is important as it helps us with some treatments, and there's lots of personalised treatments that we have in cystic fibrosis, and I'll sort of come on to that a bit more later. So really this is just to show that cystic fibrosis can affect pretty much every organ in the body. The brain should really be on that picture as well, because there's significant psychological impact of having this diagnosis too. But as you can see, it can cause lots and lots of problems. And it's what we would call a multi-system disease. What people sort of know the most about cystic fibrosis is that it usually mostly affects the lungs. So we have 15,000 miles of airways in our body. And in normal lungs, there's a thin layer of mucus on the outside of the cells that contain these like hair-like structures called cilia, which help to capture bacteria and move it along. So they work a bit like an escalator. So they trap the bacteria and then they move it along so it doesn't cause problems. But because of this mutation in the protein and then in the chloride channel, you get this thicker, stickier mucus in the lungs, which traps the bacteria and causes increased infections. And also all of that mucus sitting in the lungs causes inflammation and damage to the airways as well. So the picture really shows a healthy lung on the left-hand side with nice smooth muscle, a nice big airway, and no inflammation there. And on the right side is lots of mucus. You get this sort of inflamed, thickened muscles that cause scarring in the lungs. So often children with cystic fibrosis will have cough symptoms. They might be wheezy, and it's a different mechanism to asthma. It's because of the increased mucus and secretions in their lungs as opposed to a problem with the muscles in the airways. They might be short of breath, and they might get lots of recurrent chest infections. It also affects the digestive system. And a lot of that is because of the difficulties digesting certain foods because of a lack of enzymes in the body. And actually 1 in 10 babies who are born with CF will get a problem called meconium ileus, which is a bowel obstruction, and will need an operation in the newborn period. But essentially it can affect all parts of the gut, with lots of large poos that often seem oily or greasy and are very loose. It affects children's weight because they're losing a lot of nutrients in their poos, but also because having cystic fibrosis and repeated infections means you have a higher metabolic rate. So your body is fighting things all the time, which uses a lot of energy, and therefore you're needing a much higher intake of nutrients and energy as well. They can also get constipated. So not only can they have very loose poos, but they can also get blocked up. They can feel very sick, and sometimes that's because of the mucus that they cough up and then swallow, or just part of difficulties with the digestive symptom. Some of them will get a swollen, painful abdomen with tummy pains, and they often won't feel like eating very much as well. The DIOS is something called distal intestinal obstruction syndrome. Distal means the end part, intestines is related to your guts, and obstruction is a blockage, and often that's managed with laxatives, but sometimes does need operations. And they do often get problems with reflux, so gastroesophageal reflux disease, and that's both acidic and non-acidic contents of the stomach moving in the wrong direction, up and down the food pipe, and that can cause problems with cough and nausea and feeling unwell. It also affects the pancreas. So your pancreas is a really important organ, sort of situated behind the stomach in the middle of the body, and it makes digestive enzymes that break down fats, proteins, and carbohydrates, and then that allows the body to get the nutrients and energy it needs from those. But the problem with cystic fibrosis, as we said, is with the problem with the chloride channel. So you're still getting this thick, sticky mucus, and you get plugs of this mucus in the ducts in the pancreas. So the enzymes can't actually physically get out of the pancreas into the gut to then break down the foods. So then you get inflammation and scarring of the pancreas. So children with cystic fibrosis need to take artificial enzymes, and that's called Creon. And as babies, those tablets are broken up and put onto apple puree. And in older children, they're tablets that they take. This scarring and sort of fibrosis that is caused reduces the production of insulin, which the pancreas is important for making, and then children can get a specific diabetes related to their cystic fibrosis. So it's not the sort of diabetes that you get when you're older. It's specific to cystic fibrosis and a problem because of scarring of the pancreas. And about a third of patients with cystic fibrosis will get diabetes as a result of that, and will often need to give themselves injections of insulin as well. So it can also affect the liver. So your liver is one of the largest solid organs in the body and sits under the right rib cage. And it's responsible for making bile that digests fat in your foods, and also is important for producing proteins, hormones. It also filters toxins and badness from the body. And about 5 to 10% of CF patients will also have liver disease as well. And we screen for this every year. Because of the cells, the chloride channels not working effectively, and this is the same in all of the cells, you get thicker, stickier bile that doesn't flow easily, causes blockages, irritation and scarring, and you can get fibrosis of the liver. And we do ultrasounds of children's livers every year to make sure that's not a problem, along with blood tests as well. So it can really affect children's bones in CF. There's lots of reasons for this. They often have a lower bone density, and there's a lot of that can be because if they're very unwell, they're not moving as much, and that can affect your bone mass. Also, chronic infections can affect your bone mass. Having to have steroids for lung disease, not your pancreas not working properly, and the hormones that are produced affects your bone mass. Having a lower weight and poor growth affects your bone mass, and also delayed puberty, which can be part of chronic infections, but also as a result of being underweight, also affects your bone mass. So there's lots of reasons for children to have thinner, more fragile bones, and we do screening in the form of a DEXA bone scan from about the age of 10 to 12 every year. But about 5 to 10% of children with cystic fibrosis will also get arthritis and bony joint involvement as well. Fertility problems. So with regards to women, most will be able to have babies without fertility treatment, but if they do need it, it's because they're because of being having a chronic illness and being underweight. It can affect the regularity of your periods. They get sort of thicker vaginal mucus, which can make it harder for the sperm to reach the egg in the first place. So they may well need some assistance with this. With men, 98% will be infertile, and that's because the tube that carries the sperm from the testicles to the penis, which is called the vas deferens, is either missing or blocked. We always discuss fertility in sort of the teenage years, and again when we transition them to adults, because we have to explain about infertility, but also explain that it's still possible to get sexually transmitted infections despite this. So we have a sort of sex, drugs and rock and roll chat when they're about 12 to 13. Sometimes it can be for women that they're actually too poorly to safely be pregnant, and that can be because their lung function is so poor. They might have respiratory failure, so their lungs are just failing to work completely. Heart involvement or specific infections that are very difficult to treat can make it actually impossible for women to safely carry children and then give birth as well. So there's lots of additional symptoms, and this really is sort of not an exhaustive list at all, really. So historically, children with CF were diagnosed because parents would kiss their baby's skin and taste them as salty, and that's because of the increased chloride in the sweat because of this channel not working. So we always encourage our children to increase their salt intake in hot weather and with exercise as well, because they do lose a lot through their skin. They often have kidney and hearing complications, and that's often as a side effect of some of the medications that we use. They can have lots of problems with sinuses and extra growths in their nose, and that's all because of the cystic fibrosis. And I think really importantly, the psychological impact of having a chronic illness, and this diagnosis in particular, is huge, and we certainly recognise that. So how is it treated? Well, sadly, there's no cure, but people are working on that. But there's lots and lots of treatments. Often children are doing 2 to 3 hours a day of treatments, which is huge when you think about what children have to do on a day-to-day basis anyway. So part of their treatments are antibiotics, which they take on a prophylactic basis to try and prevent chronic infections, but also they will take that when they're unwell, and that can be either through a drip in their arm, or sometimes some of them will have ports, so a more central access in their chest wall straight into a big vein, especially if they're having antibiotics every 3 months, which some of our children do. They will do physiotherapy at least twice a day, and certainly if they're unwell, that can go up to 3 times a day. Physio is with nebulizers and without nebulizers. They'll often have inhalers because they might have asthma as well as CF2. They'll be taking the creon, so the enzyme capsules, with every meal and snack. They have a higher fat diet, so that is also part of their treatment. They have something called mucolytics, and that's to actually thin the mucus that's within the lungs, and that's part of a nebulizer treatment. Depending on their other problems, they might have to have insulin, they might have to have liver drugs. There's lots of things. On average, our patients take over 40 tablets a day. Ultimately, if children are very unwell and deteriorating, or I mean, it's unusual in childhood now, thankfully, but with adults, they sometimes progress to needing a lung transplant and oxygen on a long-term basis. The new sort of exciting treatments are the CFTR modulators, and these are drugs that actually work at a cell level to improve the function of the chloride channel. We sort of got the funding initially for these in about 2013, so not very long ago, but initially it was for compassionate use. So, those patients that had a terminal diagnosis and were palliative, so very, very unwell. Thankfully now, but only in 2019, we got funding approved for children that are over 1, and that is even now potentially over 6 months, as trials are still ongoing. But it's only for certain mutations, so it's not for all of those patients with cystic fibrosis, and it's extremely costly. So it's over £90,000 per patient per year, which is huge. But they are exciting, and they are making a big difference to our children. So we are finding that they're having to come to hospital less for IV antibiotics, that their weight is improving, that their lung function is improving. So it's very encouraging, very exciting. And we're hoping that the trials will also go on to other mutations as well. So ultimately it will be for more and more patients. So who's in the team? Well, it's me, and a specialist nurse called Karen, who I'm sure many of the schools have met already. We have 2 physiotherapists, Penny Brown and Ali Angel. We have a new dietitian that's joined us recently, Lindsay Moles, who had worked on the CF team before, and we have a psychologist, Dr. Powell. We see children every 3 months, and also we will see them when they're admitted to the children's ward here at Ipswich as well, and patients will also see the Addenbrooke's team, which is is made up of the same group of people every year, and they also support us in terms of patients that are more unwell and difficult to manage, and we contact them regularly. So what can we ask you to do to help? Well, there is lots. It's a huge burden of care for these children. Physio, medications, nebulizers, as I said, about 2 to 3 hours a day before and after school. So it's sort of having an understanding that if children are late, tired, or finding it difficult to concentrate, it may be because of all of these things that they're expected to do. Persistent cough, it's the body shifting the mucus out of the lungs. So we want children with CF to cough. It's not infectious. It's not going to cause a problem for other children in the class. And we have a lot of teenagers that are very embarrassed to cough because it sounds so wet and horrible. And they often have to cough. Ideally, we want them to cough up the sputum, and they're often reluctant to do this. That can be a real problem, but it helps keep their lungs clear, so we want them to be coughing. Enzyme supplements, so the Creon, if they get too much or too little, this can cause a lot of tummy pain and an urgent need to use the toilet, and they often have to rush off at very short intervals, and I know this can be disruptive to class, but I think it's just having things in place to understand that may be a need. Usual healthy eating guidelines don't necessarily completely apply. The old school sort of dietetic information was that we just wanted them to have lots of high fat, high sugar, high calorie, everything. So historically it was lots of chocolate, sweets, crisps, all of those things. We know that actually that's not necessarily helpful. We do need them to have a high fat diet because of the difficulty absorbing all of these nutrients, but we do want them to have a high fat, healthy diet and a balanced diet as well. So, but we have a dietitian in clinic and we work very closely with families to understand this, but they will need to eat more and higher quantities, and if they want extra puddings, we're okay with that. They can't mix with other CF children physically, which is really hard for them, but unfortunately it's too risky in terms of transmission of the specific bacterial organisms that they grow. It's not a problem for other children, but for those children with CF, it's just not safe. There are certain bacteria that cause very difficult infections for us to treat that live in damp, sort of rotting vegetation or stagnant, sort of muddy puddles. So there are some school trips and outdoor activities that might need to be adapted. But to be honest, the majority of things we're very happy for children to do, and we actively encourage them, and they can still go. More often than not, it's parents that get anxious, and we've got lots of information about what can be done to keep children with CF safe, but still be involved in these things. Children with CF, they're sort of deteriorating over a period of time, so their lung function is sort of ideally not reducing. We want to keep it as good as possible for as long as possible, but essentially it is a life-limiting condition. So they are going to die from this, but this isn't something that is going to happen acutely or quickly. So it's absolutely fine for them to go on school trips, but it often needs a bit more careful planning because they have to take extra medications and nebulizers, and there's just a bit of planning about some of those things. Some of the medications have to be kept in fridges, etc. But most of the time we can pause some things for a period of time with no problems, and we're happy to have that discussed with us. In sports, there's lots of reticence from our children to work hard in PE perhaps, but actually we want them to get out of breath. We want them to be working hard. It really, really helps their lungs. The only thing is if they've got a central line, so a portacath, they shouldn't have sort of balls directly thrown at them, but otherwise they can do everything else. There is no limitation. We want them to be included. Whether they want to do that is another matter, and we struggle to get them to do that sometimes here, but there's no problem from a CF point of view. If there is someone in class with, and I know it's slightly different with COVID now anyway, everyone's kept apart, and actually that's kept most of our CF children really, really well this year. So that's been one silver lining of COVID for us. But we don't want them near anyone with a heavy cold, because even if it is a virus, we treat children with cystic fibrosis with antibiotics for suspected bacterial infections, because they're at a significantly higher risk. We do see them every 3 months, and it's usually a half-day appointment, and that's because they have to see every member of the team. We spend quite a long time going through everything, and then one day a year they'll go to Addenbrooke's for a full sort of MOT, so it's multiple appointments, tests, so they will be out of school for that. And that can be difficult because it often gets marked down as sort of non-attendance, and actually it's just part of their treatment. Unfortunately, there's nothing we can do to avoid that. Some of our children will need hospital admissions. We try and keep the hospital admissions as short as possible, but the antibiotics will always be for 2 to 3 weeks. So even if they're in hospital for 2 to 3 days only, they will then still be having IV antibiotics to be given at home. And I think it's really making sure that the families feel in touch and about homework and extra things that they can be doing at home. Certainly whilst they're in school, they're going to the hospital classroom with no problems. That's usually pretty good. And I think every child is different. So some are really happy to talk about CF. They're really open. They give talks to other children with CF. But others are really, really private, and actually even their friends wouldn't know that they had it. But I think it's important to talk to them about this and make sure that everyone's on the same page when sharing information, because they can feel very differently. And I think, if it's part of the curriculum, either talking about fertility or cystic fibrosis in general, just be mindful of those patients that you might have in your class that have it. So in summary, it is a serious condition, but there's a whole army of people that are serious about beating it. There is hope. There's been huge changes even in the last 2 years with medications, which is really exciting, and we're all working together to make it better. There's a really good section for teachers on the cysticfibrosis.org.uk website, and this is the CF Trust. There was a film released in 2019. It is based in America, and it's called 5 Feet Apart. So it's not specifically, related to practice in the UK, but essentially it's about 2 CF patients that meet in hospital, and about their relationship, really. Lots of the patients might already have seen it, but it's an interesting watch. We're always very, very happy to speak to anyone that's got any worries about their children, pupils, any questions about school trips, anything at all. Please contact us. And the CF Trust have a YouTube channel as well, which has loads of really good videos that are quite short, with extra information as well. So I hope that's been sort of a useful overview. Please, if you've got any questions, go ahead.
Thank you, Imogen. That was really useful. Very interesting. Do we have any questions? There weren't any put through the chat bar as we went along.
I don't know if you can answer this one, but it's often difficult when you're teaching to decide how hard to push something or to work with. So if, like you're saying with PE or with a lesson, when like you've said, they could be tired, they could be having already 101 things that they don't want to do in their day, like their physio that they've had to do all their life and things. So it's I suppose it's asking for advice about trying to read situation or trying to read. But it'd be really easy for me to kind of err on the side of going, oh, poor thing, you don't, and that wouldn't necessarily bring the best, give the best. So I think I'm just thinking out loud about how.
Yeah. No, so it's really difficult for you, I think, and certainly we have got quite a few patients that will perhaps use their diagnosis. I don't want to say this sensitively, but sort of will use their diagnosis to perhaps get out of things as well, which is sort of, you know, normal children behaviour. But equally, we don't have anybody that's so unwell that they can't be doing their best at school and can't be being pushed in PE and all of those things as well. And I think it's just having that open dialogue between schools and us. If there is somebody that you feel is not contributing in lessons as much or not contributing in PE as much, and you're worried that is that because of their diagnosis and their or is it because actually they just can't be bothered, then
I mean, is on a typical day, is a child with CF likely to feel more tired or more than you know, someone who doesn't?
Yeah, I mean, they will do, because they're sort of constantly battling a series of things, really. But they might be battling infections. They might be just the general weariness of having to get up earlier than most other children to fit in their physio. And, you know, mornings are really busy for children going to school anyway. But if you've then got to get up even earlier to fit in your physio, to fit in your nebulizers, to fit in all of your medications and have a decent breakfast to also take your medications, you know, it is going to make you tired. But you know, if they're really, really struggling at school, then we need to know, because does that mean that we've not got their treatments quite right? Or, you know, is there something more that we can do to help, or perhaps change their physio around, or, you know, to make sure that they're not as tired? Or is there something else going on? Because you can have cystic fibrosis and another, you know, have really bad luck and have some other medical condition going on. So I think I think you're right. It's very difficult. And I guess as you get to know the child and their family over time, it becomes a bit clearer as well, because
it's about relationship.
Because and hopefully you have sort of an open relationship with the family, so they'll talk to you and say, well, actually, we're having a really rough time because of this infection, or because we've got to do all of this, and hopefully we would know about that. But maybe, you know, maybe they haven't wanted to tell us, because sometimes actually not, if they pretend like everything's okay when it's not, it means that they're not going to have extra treatments put on them. And so they often feel like they don't want to tell us if things aren't going well. So you know, we try and have a really open conversation. Obviously, we've got our psychologist Mel that works really closely with families, and I think most of them are really honest with us. But that will go through periods of time where they're really open, and then other times that they're less open. And as they get to more teenage years, they don't want to tell us anything, which, you know, is sort of normal. And when you ask them, "Are you okay?" It's like, "Yeah, fine." You know, that it takes a long time for us to open dialogue. But there's no easy answer, essentially. I mean, they've got a lot going on, so, but actually there's no there's no need for them to be, we still want them to be pushing themselves and doing as much as everybody else at school, you know, and if they're not, then perhaps there's something more that we could be doing, essentially.
Well, that's helpful, thank you.
Teresa Lucas has just popped in the chat. Thank you so much, very interesting. Our child leaves in 4 weeks, and so she'll pass the information on to the high school. It's just worth mentioning as well, this has been recorded, so the recording of this and the slides that Dr. Rose shared will also go up onto our website, so that can be referenced. Are there any more questions from anybody? Well, thank you very much, Dr. Rose. That was really interesting. Just on a housekeeping thing, our next medical needs in school workshop will take place next Monday, the 28th of June at 4 o'clock, and we'll be talking about epilepsy with Dr. Moodley from Ipswich Hospital. So details of that and a link and everything will be sent around in the next couple of days. Again, thank you very much. Thank you very much for your time and sharing your expertise. Have a lovely evening.
Thank you. No problem. And if any questions come through from anyone else as a result of perhaps watching at a later date, please let me know, and I'm happy to answer them if I can.
We can pass those on, definitely.
All right. Thank you very much.
Thank you, everyone.
Thank you.
Bye.
Bye.